بسم الله الرحمن الرحيم. In this video, I will speak about an important subject in the pulmonary medicine, which is hyperventilation syndrome. And I will start by definition. Hyperventilation syndrome is poorly defined, and the term is falling into disfavor, dysfunctional breathing being the alternative. And most respiratory physicians still use hyperventilation syndrome to describe breathlessness and over breathing associated with fear, stress, and anxiety in absence of any demonstrable physiological abnormality. And hyperventilation syndrome is a condition in which minute ventilation exceeds metabolic demands, resulting in hemodynamic and chemical changes that produce characteristic dysphoric symptoms, inducing a decrease in arterial blood pressure of carbon dioxide through voluntary hyperventilation reproduce these symptoms. Hyperventilation syndrome represents a relatively common emergency department presentation that is readily recognized by most clinicians. However, the underlying cause has not been clearly elucidated. Pathophysiology. Hyperventilation syndrome can occur de novo or follow a respiratory disorder that had resolved, such as an attack of mild asthma. It appears to be based on a heightened awareness of breathing and concerns as to what the shortness of breath signifies. The PaCO2 is intermittently low with respiratory alkalosis. Recordings of breathing pattern often show a rather shouty pattern. The clinical features of hyperventilation may be associated with symptoms of respiratory alkalosis such as numbness, tingling of extremities, feelings of impending doom, and lightheadedness, occasionally to the point of losing consciousness, including cerebral vasoconstriction due to hypocapnia, and intermittent episodes of breathlessness largely unrelated to exercise, although can be worsened by exercise. Sensation of not being able to take a satisfactory breath, and no history suggestive of an alternative current respiratory disorder, although there may be have been one previously. During taking the history, the patient with acute hyperventilation syndrome may present with agitation and anxiety, and most commonly, the history is one of sudden onset of dyspnea, chest pain, or neurologic symptoms such as dizziness, weakness, paresthesia, or near syncope after a stressful event. And patients with chronic hyperventilation syndrome present with similar symptoms, including recurrent chest pain, dyspnea, and neurologic deficits, and usually have had many similar presentations in the past. Acute hyperventilation patients often present dramatically with agitation, hypercapnia, and tachypnea, and chest pain, dyspnea, wheezing, dizziness, palpitation, tetanic cramps, such as carbopedal spasm, paresthesia, generalized weakness, and syncope. And the patient often complains of a sense of suffocation. An emotionally stressful precipitating event can often be identified. Cardiac symptoms. The chest pain associated with hyperventilation syndrome usually have atypical features, but on occasion it may closely resemble typical angina. It tends to last hours rather than minutes and is often relieved rather than provoked by exercise, and it's usually unrelieved by nitroglycerin. Central nervous system symptoms. Central nervous system symptoms occurs because of hypocapnia, causes cerebral artery vasoconstriction and reduces cerebral blood flow. Cerebral blood flow decreased by 2% for every 1 millimeter mercury. Every 1 millimeter mercury decrease in the arterial blood partial pressure of carbon dioxide. And the symptoms of dizziness, weakness, confusion, and agitation are common. Gastrointestinal symptoms, including epigastric pressure, bloating, bleaching, flatus, may result from urophagia. The metabolic changes. Acute metabolic changes result from intracellular shifts and increased protein binding various electrolytes during respiratory alkalosis, and acute secondary hypocalcemia can occur in carbopedal spasm, can result in carbopedal spasm, muscle twitching, and prolonged QT interval, positive Provostic and Trousseau signs, and hypokalemia tends to be less pronounced than hypocalcemia but can produce generalized weakness. And acute secondary hypophosphatemia is common and may contribute to paresthesia and generalized weakness. Chronic hyperventilation. The diagnosis of chronic hyperventilation is much more difficult than that of acute hyperventilation syndrome because hyperventilation is usually not clinically apparent, and often these patients have already undergone extensive medical investigations and have been assigned several misleading diagnoses. Two-thirds of the patients with chronic hyperventilation syndrome have a persistently slightly low arterial CO2 with compensatory renal excretion of bicarb, resulting in a near normal pH level. And these patients tend to have prominent CNS symptoms. In addition, they typically present with dyspnea and chest pain. When doing physical examination, in acute hyperventilation, obvious tachypnea and hyperapnea are present, although chest wall tenderness is common in patients with hyperventilation syndrome. It is not a helpful finding because chest wall tenderness is also found in pneumonia, pneumothorax, and pulmonary embolism, and coronary artery syndrome, and a wide variety of other serious and benign thoracoabdominal disease. Carbopedal spasm occurs when acute hypocarbia causes reduced ionized calcium and phosphate levels, resulting in involuntary contraction of feet, or more commonly, the hands, and Trovostek or Trousseau signs may be positive because of hyperventilation induced hypocalcemia. Wheezing may be heard because of bronchospasm from hypocarbia. And tremor, midriasis, pallor, tachycardia, and other manifestations of anxiety can occur. Evidence of depersonalizations or hallucination may be noted. In chronic hyperventilation syndrome, hyperventilation is usually not readily apparent, and the frequent sighing respirations, which include 2 to 3 breaths per minute, and the frequent yawning are noted. Chest wall tenderness, numbness, and tingling may be present. Characteristically, patients have multiple complaints without much supporting physical evidence of the disease. The diagnosis. Diagnosis of hyperventilation syndrome is essentially one of exclusion, but with additional confirmatory findings. There is no evidence of respiratory cause, that is to say, normal lung function, normal chest x ray, normal autosaturation at rest and on exercise to the point of breathlessness, and saturation of oxygen may even rise on exercise. And there is no evidence of cardiac cause for breathlessness. Irregular breathing patterns are at rest and on exercise. Watching the patient exercise often reveals almost instant shortness of breath and shouting breathing. There is no evidence of pulmonary hypertension, no evidence support pulmonary embolism, and no evidence of hyperthyroidism. In ABG, we will find low arterial pressure of CO2 and raised pH on blood gases and the normal AA gradient. No metabolic acidosis on blood gases, no evidence of ketoacidosis, or no evidence of lactoacidosis. Unresolved psychological issues or social phobia can be present. Differential diagnosed important pathological causes to exclude are interstitial lung disease with a normal chest X-ray and normal HRCT, mild asthma with normal basic pulmonary function test at the time of testing. Consider prefer monitoring, exercise provocation, or bronchial reactivity testing. Pulmonary hypertension, thromboembolic disease, consider cardiac echo or CT pulmonary angiogram, and hyperthyroidism and unexpected acidosis.